First of all, hello everyone, and it's me again. I've just recently been informed that there is no voice in the video number 2 and video number 3 that I've uploaded, and I'm trying to troubleshoot it for a while since I've read the email half an hour ago or so, but I can't seem to find the problem. So what I'm thinking is, given the short time period that you need to revise your studies, I think it's probably the easiest way if I record them again. So here we go. This second video, we are going to look at the treatment of adult asthma patient and pediatric asthma patient, as well as some of the side effects of medicines, and then we'll quickly move to COPD treatment and how we manage medicines in COPD patients. And obviously the last and third video will talk about only the emergency management of asthma in adults and pediatric patients, as well as exacerbation of COPD and how we manage those. So let's move on. So once somebody is diagnosed with asthma, we usually give them inhaled corticosteroid. In older days, we would like to give them PRN SABA, but nowadays we use PRN SABA for almost everyone. So we have PRN SABA, and people can have PRN SABA whenever they want it. It's a rescue treatment which is always available. So if they are feeling shortness of breath, they use their SABA, and then they'll record the use of SABA, and we'll discuss about it, that why it is important that you should record, or you should have a good understanding or memory of how much SABA you are using in a given week. Now, however, when we either suspect somebody to be in asthma, or we have a diagnosed position that this patient is having asthma, we put them on low dose inhaled corticosteroid. It means the lowest possible dose of inhaled corticosteroid that is available for that patient population. So in adult patients, we use Pulmicort 200 or Pulmicort 100, Flixotide 125, or Flixotide Ecuhaler 250. So whatever is the initial strength available for inhaled corticosteroid, we use that particular inhaled corticosteroid in these patients. And it is really important to understand that the low dose ICS is not only the initial treatment for asthma, but it's also the most desirable treatment for asthma. So this is what we aim for. For example, in a blood pressure patient, you aim for somebody to be in 130 to 80, 85 range, and you want them to be ideally on one antihypertensive for that. And whenever you add another one, you'll try to make sure that you are using the lowest possible dose, so that long-term side effects are minimized and all of that part of the treatment. So low dose inhaled corticosteroid is our first treatment, and this is where we want to be. So whenever we go up, we always try to do things to make sure that we can come down. Now, but how do we know that if we are using low dose inhaled corticosteroid? So when we need to go to the next stage, which is adding of a LABA into a low dose inhaled corticosteroid. Now, LABA is, long-acting beta receptor antagonist, which is basically formoterol, salmeterol, all those erols. Now, we do this whenever we have this criteria met. So if you look at this short-acting beta agonist SABA criteria, that if you're using it for 3 doses a week or more. Now, 3 doses, don't take it too literally that if you take 1 puff, that's like a 1 dose. Basically, it means that if you have to use 2 to 4 puffs of Ventolin, so it depends on how often you are required to use Ventolin in your patient. So if you are an asthma patient and if you are using Ventolin on Monday, so you use Monday afternoon, you use it 4 puffs, 6 puffs, say you end up using 6 puffs or 8 puffs. Now this is what you have used once. So Monday afternoon you have used it once. Now, you may need it in, say, Wednesday, and then you need it maybe Friday. So in a given week, you actually need it 3 times like that, or more than 3 times. Only then it is considered at using it for 3 times or more than 3 times. So once you have done that, it is showing you that whatever your treatment is, doesn't matter where you are on the ladder, whatever your treatment is not helping you. So it's unable to control your asthma, and you need to do something about it. So what you do, you add a LABA to ICS. Now that's where they are, excuse me, something about asthma teaching and my asthma. I won't even go there. So what happens is, whenever you use LABA and ICS together, you always try to make sure that you are not using more than the low dose. So you should use low dose and then you add LABA to it, instead of increasing ICS and adding LABA. So if you have no response to LABA at that stage, it means somehow that LABA is not working, which is very unusual in actual practice, because LABA physically open up the airways. So as an asthma patient, you feel better when you are on a bronchodilator, which is longer acting. But in very rare cases, you might not see a good response to LABA. You are still using your Ventolin a lot, or at least 3 times a week. So you stop LABA and you increase the dose from low dose ICS to medium dose ICS. So you consider increasing the dose of ICS. Now, if you have some benefit from LABA, but you're still having poor control. So for example, you might ask me how I can make sense of it. So no response or some response, but still you are meeting that criteria. So think about it, that you are using 3 times or more. So you may be using 5 times a week, right? And you start using LABA and ICS. Now you're still using 3 times a week, but you have come down from 5 to 3 times a week. So it means you are seeing some response, which tells you that you don't have no response. If it was no response, you'll still be using for 5 times. But if you are having some decrease in Ventolin, some decrease in symptoms, it means it has a response. So if it is a benefit, so if there is no response whatsoever, you stop LABA and you increase the dose of inhaled corticosteroid. But if you see there is some benefit from LABA, right, but it's still inadequate, so you will continue LABA and increase ICS to medium dose. Now, this is the second one is the stronger treatment, right? So think about it. Second one is a stronger treatment, but what is happening in the second one is the first one, the asthma is not responding to LABA at all, so there is no point in using something. Now, what is the logic of it? LABA is going to give the bad effect or side effects, but it's not giving any benefit. So you are not getting any bargain, you are not getting any benefit, you're not getting anything out of LABA instead of side effects. So you won't use LABA. But if you are getting some benefit, then you will still increase the dose of ICS, because there is benefit, but it's not enough benefit. However, if you have adequate response, right? If you have adequate response, so why there is no option for adequate response here? The reason there is no option for adequate response here is because if you are having adequate response, you are basically on the neighboring side. So you are on the left hand side, because here we add LABA to ICS. So you see here we have nothing. So we have, sorry, you can't see my finger, so you probably need to see my arrow. So here you see there is either no response, there is some benefit, and there is some benefit, but it's still inadequate. So these are the options where the benefit is not 100%. But if you are on ICS and LABA and you are doing very well, you are basically on this step, right? So we only move to the right hand side when this step is giving you this. So you are still on this step and you are still experiencing any of this. So if you are not experiencing this and you are on any step, you are happily standing there. You're not moving up and down. Now, so again, no response to LABA, so you stop LABA. Some response with LABA, you increase the dose of ICS. There is some benefit from LABA, but it's still not adequate. So you use LABA and ICS together, and you also try either a leukotriene receptor antagonist or a LAMA or sustained release theophylline. You basically use that, but at this stage, once you are at this stage, it's probably better that you start referring people to a specialist, especially after they are on any of these three options and they are still having symptoms or more use of Ventolin three times a week or more than 3 times a week. Now, after that, you'll basically just have highest possible dose of inhaled corticosteroid. And I don't think that these two will really matter to us as a general students of respiratory or just managing the 99 or 90% of asthma patients. We basically need to just worry about 1, 2, 3, because once patient reach at this stage, they need to be managed by a specialist and they'll have a lot of complex different type of regimen, right? So that's it. That's with the adult patients. And when it comes to pediatric patients, all you need to understand that there will be a difference in terms of inhaled corticosteroid doses. So the philosophy is still very same, but there will be age-related differences in the management of pediatric asthma patients. And following those age-related differences, when we come to the inhaled corticosteroid doses, we are not going to use any high dose and we are not going to use low dose initially. We are going to use very low dose. Now, as I briefly cover in the lecture as well, the reason we use very low dose of inhaled corticosteroid is because inhaled corticosteroids are still corticosteroids. So they still have long-term side effects on patients who are children basically in their developing age. So we'd like to use the lowest possible dose we can use in these patients, and only in patients where we really have to use it. So how do we do it? Now, as adult patients, you're going to have a pediatric patients, and again, if they are using their SABA 3 times or more, you are going to move them on some sort of treatment. Now, when these patients are again diagnosed in kids who are less than 1 year old, it's very difficult in those patients to really reliably diagnose asthma. So in these patients, if we have infrequent asthma, we use Ventolin with mask and we try to give them some short-term corticosteroid to see if we can manage these patients. If we can't manage these patients, then we start using regular treatment. But here we are talking about patients where a decision is being made that they will be treated for regular asthma. Now in these patients, again, you are going to start with very low dose inhaled corticosteroid, or if they are less than 5 years old, we can quite easily use leukotriene receptor antagonists because they have chewable tablets and they taste okay. So kids can chew those tablets as a daily treatment because just basically once a day. So you either give them very low dose inhaled corticosteroid, or if they are less than 5 years, you start them with leukotriene receptor antagonist. Now, excuse me. If they are still using their salbutamol a lot, then we are going to use them. If they are not on inhaled corticosteroid, we so for example, if they are less than 5-year-old and they are not on inhaled corticosteroid. If they are more than 5-year-old, they will be on inhaled corticosteroid. But because if they are not on inhaled corticosteroid initially, we then put them on inhaled corticosteroid regardless of the age. However, if their age is less than 5-year-old, we add a leukotriene receptor antagonist to them. If their age is more than 5 years old, we add very low dose inhaled corticosteroid plus leukotriene receptor antagonist. And more than 5 years old, we add LAMA. Now again, try to understand and don't get confused between these two options, because in the first case scenario, when kid is under 5-year-old, we are not using inhaled corticosteroid at all. We are basically just using leukotriene receptor antagonist. But when it comes to the second stage, although it's repeating here, but imagine you have a child who's 3 years old in front of you. So you basically would have been using leukotriene receptor antagonist or singular here. So kid is less than 5, you are using leukotriene receptor antagonist. So when you go to the second stage, this will stay the same as it was, but you basically add very low dose inhaled corticosteroid. On the other hand, if you are dealing with a kid who is more than 5-year-old, you might be already using very low dose pediatric dose inhaled corticosteroid, so which is here. But now in this case, the addition will be that you are adding a LABA to this child. Now again, remember the adult one, no response to LABA whatsoever. You stop the LABA and you increase the dose of ICS from very low dose to low dose. If there is some benefit from LABA, but control is still bad, you continue using LABA and you increase the ICS from a very low dose to a low dose. If there is benefit from LABA, but it's still inadequate after using LABA as well as low dose ICS, then you use LABA and low dose ICS and add leukotriene receptor antagonist when it wasn't added or it wasn't the part of the treatment. But if it was the part of the treatment, then basically you just add you just increase the dose of inhaled corticosteroid to meet that strength. Now, once patient is still struggling with this combination, just like adult, we refer them, and here it will be complicated case. So I don't really see the need. Like, I'm not saying that you should not study about it. You can study it. It's good to know these things, but you don't need to know these things at this stage because it's going to confuse you even further. Because it need a lot of dose increase, decrease, close follow-up, trying different techniques, trying sometimes different inhalers, trying different strength, all those cromolyn kind of sticky inhaler start playing in. Sometimes oral steroid kick in, burst cases of oral steroid to make sure that the patient is conditioned. And in some patients, you need that. Usually not more than 5% of patients go into these last two columns. It's mainly these three that we deal in community and majority of our patients. So again, quite similar to your adult patients, the pediatric asthma patient. Now, what I should like to do here is I'll quickly go through the side effects of the rest of the medicine. So let me bring the slides up. So what I've done is I've even make it more concise, so that's all you need to worry about in terms of side effects of these medicines. So we know there's inhaled corticosteroid, we know there's SABA and LABA, so they share the pharmacological action, so they're quite similar side effect. LAMA, which is long-acting muscarinic antagonist, and we are going to discuss them in COPD shortly. Leukotriene receptor antagonists, which are singular, basically one drug, and cromolyn. So inhaled corticosteroid, the most common side effect that you need to be worried of is oral candidiasis, because a lot of the patients don't properly rinse their mouth after taking the drug, especially if they are in acute attack, bad days of asthma where they're using a lot. They may not be feeling really well, so usually they are able to do it, but in those cases sometimes they miss. Voice hoarseness, so their voice can become a bit hoarse, bit husky, and if they have a profession such as lecturer who need to record these lectures and who is having asthma, so sometimes voice hoarseness can be a problem. It's not as bad as it was a couple of days before. Cough, rebound cough is probably an issue. If cough is a major concern, then it's better to use aerosol instead of dry powder inhaler, because dry powder can cause more cough. Growth concern in kids are real, but basically excuse me, basically just slow down growth to some extent. So eventually kids exposed to inhaled corticosteroid can grow normally. Infection and pneumonia is another side effect, especially in elderly patients, especially in COPD patients where we use quite a high dose. SABA, tremor, palpitation, dry mouth, cramping of the muscles because it can cause hypokalemia, and low potassium level, as you know as a nursing student, can cause serious problem with muscle depolarization, repolarization. So cramping is also quite common when especially patients are using a lot of SABA in acute attack. LABA, headache and palpitations can be a big problem. Dry mouth can also be a big problem with LABA. LABA and LAMA, as you can see, dry mouth, constipation, urinary retention, all of these are anticholinergic side effects. So dry eyes, blurred vision generally, and they are related to the overall exposure of LAMA in blood, because if you use LAMA regularly, a part of that is also absorbed into your systemic circulation, and that's where these side effects come up. Leukotriene receptor antagonist, common side effect, headache, GI upset, nasal congestion, and flu-like symptoms are quite common side effects being reported with leukotriene receptor antagonist. Hepatotoxicity has been reported with older molecule. There's a possibility that yes, it can cause these problems, but in recommended doses, most of these side effects are quite manageable. Cromolyn, apart from unpleasant taste and cough, there's also throat irritation, can cause reflex bronchospasm in few kids, so need to closely monitor in the earlier days. No, I don't want now. And GI symptoms like a bit of nausea, diarrhea is common, especially if kids are not inhaling it properly, and a lot of that is going in the tummy because of the poor inhalation technique. It's better to rinse the mouth with cromolyn as well, so that you minimize the exposure of that being absorbed from your mouth. It's really important that a lot of these side effects are manageable when you are not using normally recommended doses, but during the acute worsening of the treatment, often these medicines are used in excess of the recommended doses sometime to control the bronchoconstriction, to control the attack, to manage proper breathing in these patients. And because of that, these side effects even become more important when we are acutely managing these patients. Now we quickly move to COPD. Now the good thing about COPD is COPD treatment is very straightforward. Unlike asthma, you only will have three situations. Either you will have somebody who is newly diagnosed with COPD, so mild COPD. With COPD, you always have pulmonary function test, because the importance of pulmonary function test in COPD is for prognosis reason. So you need to grade the patient in their survival, and then you probably prepare them mentally and physically how to manage their disease. You also need to show them number, because a lot of them were still smoking when they come to your care. So it's important that there is always a number in front of them. 60 to 80 forced expiratory volume over 1 second. You got mild category, moderate is 60 to 40, and less than 40 is severe. You start them either on LABA or LAMA. There is no preference whatsoever. They can start on LABA, they can start on LAMA. Increasingly people use LAMA, because when they want to use LABA, they can use LABA and later on LABA with inhaled corticosteroid. However, if the patient is not responding well, at that stage, you either use LABA and ICS, or you use LAMA and ICS. Now, in patients where ICS is not showing any difference whatsoever, in those patients, you can use LABA and LAMA and don't use ICS. Patients who are really bad, going to the end stage COPD, less than 40, apart from oxygen and supportive treatment, you use LABA, LAMA, and inhaled corticosteroid together. So this is how simple it is. You start with either LABA and LAMA, and you always have rescue treatment like, short-acting beta receptor antagonist, Ventolin inhaler. Whenever they are shortness of breath, they can use that. If they are not really functioning well on LABA or LAMA, you switch them over. If you are using LABA, you use LAMA. If you are using LAMA, you use LABA. If they are not getting good control, then you try to use LABA with inhaled corticosteroid or LAMA with inhaled corticosteroid. And if that is not giving any benefit, then you use LABA and LAMA without inhaled corticosteroid. But once they deteriorate to the last stage, you just use all of them, because it's all about just maintaining a decent quality of life in these patients. So I hope that covers all of your regular treatment for childhood asthma, adult asthma, as well as COPD treatment, and I hope it makes sense. So now I'm going to stop this recording, and we'll prepare the third and last video about the emergency treatment of these diseases. Thank you very much. And I do apologize for the audio problem, because I checked the first video, it was working fine, so I assume second and third must be working fine, because I did nothing different for the second and third, but somehow they were not working. So sincere apologies for that, and I hope that your Christmas and New Year break was better and not like me having a second attack of asthma in last 6 months. Okay, good luck with your